Hello, and welcome to Respiratory Motion Spotlight Session. My name is Joe Tabakhorst, and I would like to thank you for joining me today to learn about our exciting new technology, ExSpiron. ExSpiron is the first and only non-invasive monitor that provides hyper and hypoventilation detection of tidal volume and respiratory rate. The ExSpiron quantifies real-time ventilation to aid in the assessment of a patient's respiratory status. You all are already aware of what minute ventilation is. Now let me introduce you to predictive minute ventilation to assess whether minute ventilation is trending abnormally. We call this minute ventilation predictive, or MV-PRED. MV-PRED is the value that is unique to ExSpiron, that is the normal minute ventilation at rest, based on a patient size and birth gender. ExSpiron minute ventilation could be useful for patients in several ways. To quantify workup breathing and characterize ventilatory compromise, this data may be useful in admission and treatment decision protocols. To monitor patients in step down or on the floor for early signs of respiratory decline. To help assess extubation readiness and monitor for the need to re-intubate. Hypoventilation is a problem seen in the ICU, usually as a reaction to pain medication or sedation. Here's what hypoventilation looks like on the ExSpiron. The middle trace shows the patient's minute ventilation trend. The circles show where on the trend line minute ventilation falls below 40% of the expected for a sustained amount of time. The number in the circle shows that the patient is hypoventilating. This patient is likely heading for trouble, and without intervention, may eventually develop metabolic changes detectable by oximetry and capnography. Note that the SpO2 and respiratory rate were still normal in this patient. In today's need for understanding respiratory status, specifically in managing patients who may have a viral pneumonia, ExSpiron also gives you data to detect and characterize hyperventilation. Patients present with an increased respiratory workload as the body attempts to compensate for lung capacity compromise by increasing their respiratory rate or tidal volume, or both. Any increase in volume of rate increases the minute ventilation. If patients with increased minute ventilation remain unsupported, they may eventually deteriorate. The patient's ventilatory system will no longer be able to compensate. Insufficient gas exchange within the lung occurs, and hypoxemia and respiratory failure ensues. With ExSpiron monitoring, the increased minute ventilation is detected, and both tidal volume and respiratory rate are displayed. This gives early warning and helps characterize the patient's ventilatory status. For example, it is not uncommon for COVID patients heading to hypoxia to present without much dyspnea because they compensate for declining lung function by increasing tidal volume. The ExSpiron would enable you to see this. Monitoring just respiratory rate misses those patients who compensate for their hypoxemia with increased tidal volume. Monitoring just for hypoxemia gives you a late indicator of respiratory distress, not until the patient is already in trouble. Evaluating changes in tidal volume and minute ventilation may provide early indication of changes in the compliance of lungs. This information may be useful to guide treatment decisions and ventilator settings. In particular, it characterizes the respiratory status of atypically presenting patients. For example, the COVID patients who have high tidal volumes without increase in respiratory rate of overt dyspnea, who some clinicians believe benefit from earlier interventions such as proning, non-invasive positive pressure ventilation support, high flow therapy, medication therapy, etc. Some clinicians also prefer lung-sparing ventilator settings for these patients. One of the benefits of ExSpiron's ability to quantify work of breathing is it allows you to protocolize decisions that today are made subjectively. This is a protocol developed by a center that is currently using ExSpiron to triage COVID patients and guide clinical pathways. They quantify work of breathing by evaluating the patient's degree of hyperventilation above the predicted minute ventilation. An atypical case may present without traditional signs of shortness of breath, but with quantified work of breathing, their actual respiratory workload can be evaluated and the patient triaged appropriately. Due to the compact size of the monitor and easy to access sensor sites, ExSpiron can be placed on patients waiting to be seen. When the patient is examined by a provider, their trending minute ventilation information is readily available and can be used in evaluation. The ExSpiron monitor measures minute ventilation using bioimpedance. When compared to spirometry, the ExSpiron's measurements of tidal volume and minute ventilation is 90% accurate. ExSpiron consists of a freestanding monitor that displays the patient's real-time respiratory status and trends, and a single-use pad set electrode. The monitor has a touchscreen, easy-to-use interface, stands on a counter, or mounts on a pole. It runs on AC power and has an internal battery for transport. It can be connected to external data display, patient record, and nurse call systems. The pad set is comfortable for the patient, easy to position, and available in pediatric as well as adult sizes. Minute ventilation monitoring gives the first sign of impending respiratory failure. It is useful in many care areas of the hospital, including the ICU and ED, and even the general care floor. ExSpiron connects to both existing nurse call systems and some remote display systems. Another benefit of ExSpiron is that it has been shown to have very low rates of false alarms compared to SpO2 or end-tidal CO2 monitors, where patient movement can displace sensors and cause false alarms. ExSpiron can be used to monitor patients who are on pain medication or sedation, or on forms of non-invasive ventilation. In the ICU setting, the ExSpiron can be helpful in extubation decisions and procedures. Prior to extubation, ExSpiron minute ventilation is synced to the minute ventilation of the ventilator. After extubation, or during the spontaneous breathing trial, ExSpiron uses that ideal minute ventilation that was synced from the vent and compares the minute ventilation of the spontaneously breathing patient to that value. There is an expected dip of approximately 25% of minute ventilation, but patients ready to breathe independent of the ventilator typically return to the previously established ideal minute ventilation within 60 to 90 minutes. If the expected return to baseline does not occur, the patient may require continued ventilator support. ExSpiron can also be used to continue to watch for respiratory deterioration of extubated patients as they are discharged to lower acuity care areas. The early warning of decline may allow reintubation decisions to be made while the patient is stronger and without the need for rapid response. In the first trend of this slide, you can visualize the typical extubation trend with an initial dip in minute ventilation immediately after extubation, and a return to baseline within 90 minutes. In the second trend, you see an atypical course where the patient is extubated, has a small dip in minute ventilation, but does not exhibit the typical recovery. Minute ventilation improves slightly with the expulsion of a mucus plug, but the patient returns to hypoventilatory state. During this period of hypoventilation, the bedside monitor did not alert the nurse to hypoxemia. This slide demonstrates how ExSpiron was used on a patient to monitor effectiveness of non-invasive positive pressure ventilation and high-flow nasal cannula. In this graph, the green area represents the ExSpiron predicted minute ventilation. At point A, we can see the ExSpiron shows a much lower minute ventilation than what is set on the BiPAP, probably indicating that the mask has lost its seal. However, the BiPAP has not registered the loss in volume. At point B, the patient is placed on high-flow nasal cannula. However, this is not sufficient to support the patient as the minute ventilation climbs well into the threshold parameters for hyperventilation shown in yellow. Notably, the respiratory rate was largely unchanged during this 2.5-hour stint of increased worker breathing, remaining at an average of 25 breaths per minute. Making the decision to intubate is often a difficult one, but positive patient outcomes rely on it being a timely decision. Access to quantifiable minute ventilation data can aid in clinical decisions regarding escalation of care. The results of ExSpiron monitoring have been well documented in over 30 peer-reviewed clinical publications from top-tier academic centers, validating its use in PACU, ICU, procedure room, and general care floors. In conclusion, ExSpiron non-invasive minute ventilation is a proven, highly reliable way to assess respiratory status and gain early warning of respiratory deterioration. It is equally powerful at detecting hypoventilation and hyperventilation. Therefore, it has applications in many different care areas for patients with many various underlying clinical problems. Monitoring through the Continuum of Care, intensivists and other clinicians now have the ExSpiron non-invasive tool to help them make decisions about a patient's respiratory health and drive optimal clinical outcomes for patients every day, everywhere. Please feel free to come fill out our form on our link and someone from our team will reach out to you. Thank you and have a great day.